If you're a urologist and you want to pursue a career as like an oncologic surgeon with the biggest surgeries, I think that that's the most demanding part. So which means then you have to be prepared for a relatively long learning curve. But it's also the most interesting and something you can grow with for the rest of your career. So it's not like you learn everything in 2-3 years and then you're done. For me, I've done cystectomy, started with open, then some laparoscopic, and now robotic cystectomies. I still learn and do things all the time in my whole career. You're developing. So I think if you want to do the more challenging parts of urology, it's also going to be very worthwhile for your career and for your actually life as a urologist. The system in the US and Sweden are different on who is sort of responsible for the muscle invasive bladder cancer. In Stockholm, we have a public healthcare system. In the US, it's more driven by private hospitals, basically. But in Stockholm, there's only one hospital that is allowed to do cystectomy. So all the cystectomies are centralized in one hospital, in Karolinska University Hospital, ranked among the top 5 in the whole world as hospitals right now. So I think that if you have a system that can specialize like that, you will also have very good results. In the US, it's more competitive, but their economy drives it still to be centralized. In Mount Sinai, where I'm in New York, almost the same amount of cystectomies as we're doing in Karolinska and Stockholm. In US, it's driven a lot by economy, so that if you have a system which only performs 1, 2, 3 cystectomies a year, it's not economically viable, basically, and they don't want to do it because it's a lot of work and not so much money. In Sweden, there was a big problem for many years that did not specialize, so that all small hospitals did 2-3 cystectomies a year. And we know now we have this big registry that the outcome for the patient is much better if you centralize. So I think for patient, you have to centralize. The question is unblocked TURBT. No, I don't. And no one that I work with in New York is actually doing unblocked TURBT. Personally, I don't do so many TURBTs because I just get so many referrals from us in the
mainly the big surgery.
For me, then I think it's of course great to have the proper pathology of, so if the tumor is relatively small, then you can actually do it unblocked, take it out unblocked. Problem is that sometimes the tumors are large, you have to morcellate, and then you have to do biopsies afterwards to see about the stage of the tumor. And I think that's, like, for me, the drawback. Theoretically best for the small tumors where you actually can do a perfect unblock and you get the stage of the tumor without actually having to morcellate it. I think it's good, but I do think it's a problem when the tumors are getting bigger. The discussion about transperineal compared to transrectal biopsy, for me, it's coming from Scandinavia, where most centers now have gone over to perineal because you get less infections. I think it's much better for the patient to have perineal biopsies because you have less severe infections. The problem for me as a surgeon with transperineal is that your biopsies come in another angle, and it's more difficult to predict exactly where is the tumor. When I do a prostatectomy, if I have transrectal biopsies, I'm much more sure. In combination with transrectal and MRI, I think is superior to perineal, but for patient, it's perineal biopsy is much better. Also, the type of biopsy is also very important depending on if you have a screening system, because for screening, the combination of MRI and prostate biopsy is very important. There is some sort of mismatch between treatment and screening. For screening, you don't want to find all these unnecessary tumors, of course, because it's important to not biopsy in patients that you don't find clinically significant cancers. So for that reason, it's important. The problem is then when you do surgery, if you only have a targeted biopsy, you are very likely to have tumors in other areas of the prostate. So when you do like a prostatectomy, you may have less information about that. So that's, I see, a problem with the new screening policy of MRI and biopsy.